start?
We have begun. I want to finish up what we have in immune. And so you might remember we had talked a little bit at the very end about those four or so different types of hypersensitivity reactions, including standard allergies, all of which even when they're severe could lead all the way to anaphylactic shock, but hives, rashes, etc., etc. Uh, on the other side here, you remember we talked a bit about this is the classic example of the blood transfusion mismatch, because when effectively what happens is the antigens and the antibodies conflict, and but the problem is they're breaking apart red blood cells, and now what do we do with the hemoglobin? It gets basically stuck in your kidneys. That's the big problem. It can cause significant kidney failure and long-term kidney damage. We'll talk about this a little bit. These immune complexes are characteristic of autoimmune diseases, particularly one called systemic lupus erythematosus. I'll talk about that in a second. That's there, but these trouble is they invade organs, and lupus is the number one cause of kidneys to fail and need to be replaced or transplanted is diabetes. Number two, systemic lupus erythematosus, because it jams them with antigen antibody complexes, which is very similar to what diabetes does. And then lastly, the delayed reaction. We talked a little bit about you remember the tuberculosis test, things like that, various kinds of it's really how poison ivy works to a certain extent. It's how contact dermatitis. You get a new pair of sandals, and depending if you have leather, between leather and perspiration, you have various types of tanning agents that they use, and a lot of times they'll be released to get into your skin. I've seen tons of that over the years. So that's just showing you how graphically it doesn't do anything for me. Which brings us to this. So really that's sort of the heart of the whole idea is this transplantation and tissue reaction area that's there. Uh, all of these things, to me, are somewhat interesting in that regard. Uh, tr- Transplants have been around for a very long time. I have, yeah, personally, I've done autogenous bone transplants. So there's taking bone from one part of the body and moving it to the other. We have bone banks. We have cadaveric bone. We have, I mean, so bone is very well known. Corneal transplants have been around for quite a little while. And so, and the other things are not, some of them are pioneered here in Pittsburgh. Liver transplants really made their mark here in Pittsburgh. We have the Starzl Institute. The University of Pittsburgh recruited a doctor who was very advanced in transplant named Thomas Starzl back in the late 70s to come here, and he basically converted Pittsburgh to maybe the biggest transplant center in the United States. So a lot of that stuff was developed here. Bone marrow has been around for a while. Hearts, the earliest heart transplant was done in South Africa by a doctor named Christian Barnard, I think in 1965. So there's nothing unusual about that. And I myself I've done in the office, I've done skin transplant. I've done, they're called autogenous grafts, and we're going to get to that right now. Nevertheless, unless you're using something that's totally compatible, there is always going to be a tissue reaction. That has to do with basically here. Autografts means, and this is what I was telling you what I used in the operating room, taking bone from one part of the body and moving it to another part of the body. It's their bone. They're not going to react to it. Okay? Unless you inadvertently did something to make it foreign, you contaminated with it in a surgical sense. On the other hand, isografts, very few people have an identical twin. In that case, if they have an identical twin and there's no reason to suspect there's any genetic incompatibility, again, that would be viewed as self because theoretically, genetically identical. You don't see a lot of that. Okay. When I would do skin grafts, we do skin flaps and transfer flaps. In other words, you take pieces of skin from one area and you move them for coverage to another area. And typically most skin grafts are done that way if you didn't know. Someone has a bad burn or a bad accident, and there's going to be a lot of scar that has to be covered. A lot of times you'll end up, burns being the most common reason. You'll take it from one area, and you'll take a skin that you're going to make it so thin that new skin will form, and you take that skin and you do that for cover on another area in the hopes that that'll take. And that's really the sort of the secret sauce for these reactions. Yes, ma'am.
I've seen just on the internet and stuff, people will need to have cover their nose done. Why don't they take skin from somewhere that doesn't grow hair? Because I feel I always see people with hair starts growing on.
Yeah, there aren't that many areas that don't grow hair. It's a good question. That's the problem. Palms and soles don't grow hair. External genitalia don't grow hair. That's about it. And so you're really limited in that regard. And there's nothing perfect, so to speak. You just because this is plastic, sir. Plastic is light years changed over time. They're so much more advanced today with things that they can do. We work with a plastic surgeon. I mean, he was doing amazing things then. Now they're just shocking. So I don't really have an answer, but I think it's just in general, taking skin from a palm and a sole is very hard to heal. And certainly taking from the external genitalia would be for all the problems too. So moving on. Most grafts that are done, and I was fortunate, any of those what I call pinch grafts all took. The ones I did in the office, well, I was very happy with that. And a lot of that has to do with being careful and avoiding infection and those kinds of things. And sometimes you're happy that luck is on your side. And the typical graft that you and I hear about, whether it's a kidney transplant or a bone marrow transplant, is an allograft. That means from another person, but same species. And when you hear, so another human being. And again, we test for compatibility. And then lastly, and they're not uncommon, the xenograft. Xeno means from a different species. And the example they'll show you in this PowerPoint was one of the earliest ones and still used. They use heart valves from pig heart valves. We were using porcine, which is pig-related grafts, in tendon and ligamentous areas years and years ago. This was 40, 50 years ago. So there's a lot of science behind it. Some animals are more genetically compatible to you than you would think. Theoretically, why wouldn't you use, if we're so similar to the monkey, ape, simian, whatever the appropriate term is, family. Shows you I don't know any of that stuff. But if we are so similar, why don't we use those as grafting materials? Apparently, it doesn't work as well as, let's say, porcine does for whatever the purposes are. Wish I knew. But that's a very advanced science, and you never can tell. For many of you, you're in a clinical field and you end up working at UPMC. You might end up on a floor where they do a floor, an area where that's what they specialize in. So a lot of these, what it leads to are these graft versus host diseases, and so it's different. So there's going to have to be some type of response, a rejection phenomenon, if you will. And so we try to match as much as possible by those MHC antigens. I commented on that before. And the greater the similarity, the less the problem. The greater the difference, the faster and more aggressive the problem will be. That's when they do, we call it tissue typing, to make sure it's the appropriate match. And even in that, okay, you almost, for years, if somebody had a heart transplant or a kidney transplant, it meant they were on immunosuppressive drugs. And now you're limiting the ability of your immune system to fight other problems for the duration. And now, as you're seeing here, that now the tendency has been to add bone marrow stem cells along with that, so that a certain amount of compatible white blood cells would be there and maybe limit the scope or limit the severity of the immunological response. It's very interesting. So there's been a lot of advances in that. Bone marrow transplants were really, when I We were starting to hear about them. We were in their infancy. All of these things. So, like I said, it's been 25 years since I worked in a hospital or was, practicing medicine and no matter what field you're in, you're constantly hearing about this stuff as you go to continuing education seminars. So, I mean, I'm sorry you're stuck with an old guy out of the loop. You're going to have to deal with it. Don't start. How are you? Good. The glasses are not here today. All right. Let's hear it. I'm afraid to put them in my eyes. I'm so frightened about putting anything in my eyes. I never would have thought. My sister got them as soon as humanly possible. I think when the first pair came out. What? No. Well, she worked for the biggest company who made contacts, Bausch and Lomb. What? No, not this buckaroo. I'm not putting anything in my eyes that doesn't belong here. We have a word for that. Chicken. Chicken. Covered. All the stuff I just told you about. This is the autoimmunity. And it can be from antibodies. Okay. As the body produces antibodies called autoantibodies, you're attacking yourself. Sometimes we don't know why it occurs. Sometimes it occurs because we're making antibodies to fight an infection, notoriously streptococcus. Most of the damage when you get a strep throat, your throat will get better. Problem when it's not treated properly, either undertreated or inappropriately treated or not treated, okay, is the antibodies to fight the streptococcus attach healthy tissue. They attack linings in your joints. They attack linings in the heart valves. They can attack your kidney, as you'll see here shortly. That's the big. We call that in science. That's called an indirect method. It's not from the bacteria damaging the tissue directly by either producing a toxin or just damaging it as it grows into the cells, but indirectly, sort of hijacking your immune system. So it can hijack. So your immune system could be hijacked by things that you're learning about, many of you in micro, with various pathogenic bacteria or viruses. And viruses mostly damage you by way of your immune system, or by activating T cells that are damaging as well. And so there's lots of autoimmune disorders, but there's no real universal cause. There's a lot of theories. There's association with viruses. There's a lot of things that point. And so years ago, we used to have probable or suspected. Now there are things, as you'll see in this next, I'm getting up. We know these are autoimmune disorders. They're now no longer probable. With advancements in science, we've been able to detect either altered cells or altered antibodies. The reason I have put this up here, I'll tell you the same anecdote I tell to everybody with the same thing. It involves this chart. This is a normal distribution. You're all familiar with that. Most of you have statistics, if not here, you had it in high school, means, medians, that whole thing. When you scale an exam, the basis is figure out what the mean score is and how many standard deviations. So if you do it that way, and a lot of colleagues do, I don't. Particularly, I have my own idea of what the scale should be. Nonetheless, that's how you scale it. So in a Gaussian or normal distribution, you have half on one side, half on the other. This is the severity is the x-axis. The frequency would be how many autoimmune diseases fall into this category. Why it's so significant, I give it to this class. The vast majority of the classes I teach, particularly in anatomy and physiology, have nursing and health science students. Still to this day, the vast majority of them are women. And the people who are at greatest risk statistically are women. Most common, 80% of autoimmune diseases affect women in the second through fifth decades. That means ages 15 through 55. So many of you are in the wrong side of that particular demographic. It's true. Now, some favor men more than women. Okay. But there's no hard and steady rule for these types of things. When you're a rheumatologist, in the back of your mind, you go, that's mostly women, it's mostly men. guide your diagnosis. But rheumatoid arthritis, rheumatoid rather, lupus erythematosus, psoriatic arthritis, I actually have a very much more common. Just to give you an idea, 80%, it's a big number. This is the good side, 50% with minimal severity. 10% means typically for these diseases, 1 out of 10 have been diagnosed with it and it doesn't impact them at all. They either don't have to take any medicine or have to take medicine occasionally, or it has absolutely no impact on their daily activities, how they work, anything like that. Everything anybody else does. That's a good thing. The next 40% have minimal impact. What does that mean? Probably they have to take medication. Yeah, it probably hurts, but they can still carry on with all activities in your lifestyle. They're not impaired for working, from the kinds of jobs that they do. There's a minimal amount of degree. So that 50% largely are either unimpacted or limitedly impacted. And obviously, as you're getting from good to bad, it's getting progressively worse. This side you don't want to be on. That 40%, the 40% on the downside, all of those people have this in common. They're taxed, they're ADLs. By this time in your career, you should know what an ADL is. I know what the acronym stands for because you're going to hear it a lot. Activities of daily living. Putting your clothes on, going to the bathroom, taking a bath, taking a shower, okay, doing stuff around the house, making yourself something to eat. Man, you have no idea, if you're not familiar with someone who has that, somebody in your orbit has that problem, how impactful that is. You no longer do things that you must do in order to survive. Be part of the world as well. That is a very severe impairment. And on top of that, they're probably taking medicine. On top of that, they probably can't work. On top of that, they may need help on the full time. And this last 10%, you don't even want to think about. Here's the end. Watch that last 10%. This is, oh goodness, 50 years ago. We, still a student, hadn't got my doctorate yet. And about a half dozen of us were doing a rotation at Moss Rehabilitation Center in North Philly. It was part of an extension of a hospital based off of a medical school. And we were touring, we were doing rounds with the rheumatologist, very nice fellow. And basically when you do rounds as doctors or student doctors, go into the room, he'll examine the patient, he'll talk to the patient, you'll examine them, you'll discuss it, and typically it's very low key, and you get a lot of information. This person has this person just had this operation, etc. We got to one room, it was dark in the room, it was a double room, you could see only one bed far to the wall, away from the door, was occupied. He said, I want you to be very quiet and just stand in the back, just in the doorway. Don't go up to where the patient was. All we could see was someone in bed. It was evident that this individual was female, could not have weighed more than 80 or 85 pounds, in a fetal position, scrunched up, kind of making what we would describe today as muling sounds, like that type of stuff. And he very gently went over. When he touched her, you could see the sounds increased in obvious pain. He reached over, he would just whisper in her ear, try to touch some different areas, very limitedly, just minutes or so. And then he kind of went to us and almost directed us, okay, go out the door. Walked away, not only from the room, we went to one of the little conference room off the nurse's station. He sat down, he said, what do you think she has? And we're all beside ourselves. How old do you think she is? We couldn't even guess the cards. He said, I want you to know that she has severe rheumatoid arthritis. It's common autoimmune disease. She's probably, I think my recollection is, he said 25 or 26 years old, and 6 months ago, she was as normal as you and I. And in a period of 6 months, she has total care. And he said, I doubt seriously if she will be here for another 6 months. She will not live another 6 months. That's how severe autoimmune, and take it to heart. If you're a person who has a certain amount of depending on what you think religiously or non-religiously or otherwise, sometimes be very thankful for what you have. You see something like that, it's stuck with me for my entire life. The severity of these diseases, and I have one, but I no longer have chosen to treat it because I didn't like how the biological medicines of today, not that they're bad, I just didn't like the way they made me feel. It wasn't so severe that I couldn't do without them, and figured taking better care of myself, etc. Eat properly, more, that whole deal. Try to get more healthy. I have to stop going out and drinking all night long at the bars. Like that really would ever happen. Oh, moving on. So here, this is streptococcal. Okay. This can come from a strep throat or a condition of the skin called, that a lot of you have had, called impetigo, which is sometimes staphylococcal and sometimes streptococcal in origin. From the streptococcal one, it causes your kidneys to shut down. It builds up those antigen antibody complexes, and they clog the filtering apparatus of the kidney, which you will come to know are called the glomeruli. Hence the name of glomerulonephritis. Is it common? I would think so. My stepson, who taught for about 5 years, taught physics here, had this when he was in high school at Seneca Valley. Okay. From a strep throat. I mean, it wasn't, it's that kind of common. Like you'll know somebody who's had it at some juncture in your life. No question about it. All of a sudden, he couldn't go. He's got back pain. Oh my God, boom. Nah. We covered this a little bit in endocrine. This is autoimmune, but it's interesting. It causes an overproduction of thyroid stimulating hormones, and that creates that. Remember, you had that exophthalmic goiter, the popping out eyes. So, and other things that go along with it. That's just where they recognize it. Diabetes. We now know, yes, it affects pancreatic beta cells, but we see antigen antibody complexes in the kidney, just like they get way down here. Systemic lupus erythematosus. They get antigen antibody complexes in all sorts of organs. That's a very interesting disease. It's kind of like we call it the great masquerader, like mononucleosis, like syphilis. People get, those are all immune-based phenomena. Okay, those are disorders that work through your immune system. So it could be anything from scratchy or sore throat to fatigue to feeling lousy to having a rash. It's a very challenging diagnosis to make for the clinician. And something, I love diagnoses. My favorite things. There's things that can cause your red cells to burst. MS has a very strong statistical association with a particular herpes virus that causes a common disease that I'll bet almost all of you had, called roseola, human herpes virus 6. Now, is that the cause? We don't know. Is there a statistical correlation between very high levels or titers of this and people with MS? Yes, there is. That doesn't mean cause and effect. A lot of the, there are things there. These are statistical tendencies, but not proof positive. But we know that those are immune complexes that affect the myelin of and the central and peripheral nervous system. Is that thunder? Oh, it's gonna scare the dog. Not the cat. He's ready. Cat doesn't take any poop, if you know what I mean. Pernicious anemia. When we talk about this a little bit in digestive, it affects something called intrinsic factor. Rheumatic fever, again, streptococcus is a big player in this. And again, all of these things are part of it. It's very, very interesting. And I mean, if you know somebody with ulcerative colitis, it is awful. These Crohn's disease and ulcerative colitis, The gal I dated through my high school years and into college, I'd lost track of her for, oh my goodness, 30 years or so. And she contacted me when I started teaching at Chatham. The old let's get back together thing again. She had to have, we didn't know what was wrong with her digestively. She always had problems. She had to have her entire colon removed because of ulcerative colitis. That created was they had to bring down her. You learned about digestive in lab this week. Her jejunum, they had to bring that down to and sew it to her rectum. It's called a J pouch to actually make a. So she didn't have to have a bag to an ostomy bag. I mean, I never read. She was living in California. I didn't read. Didn't have a lot. I felt bad. Strange for my daughter. Sad. And this is, I talked about it a little bit with my micro class. This is, it's such, this affects directly the single most important cell of your immune system, the helper T cell. And because of that, and macrophages also, which are another linchpin of your immune system, and eventually the helper T cell population not only is damaged irreparably, but it converts other helper T cells to factories to make more of the virus to affect the rest of your helper T cells. So it poisons the line. And it takes average time, 2 to 10 years. Sometimes it can be much more rapid. Sometimes it can be even slower in the absence of adequate treatment. HIV is eminently treatable if people get treatment and take good care of themselves. If they don't, or if they're misdiagnosed or afraid to go in and be diagnosed, then because AIDS is fatal, it means it's going to shorten their lifespan. That means that you have reached a number of HIV where it has gone below a particular support level. So at that point, when you have that few helper T cells, your immune system collapses because without them, you can't function. And I told it in micro, and I just told it to the 1220A class. I mean, we didn't know what this disease was. I'm treating patients with AIDS in Philadelphia back in 1976. The word AIDS wasn't in the lexicon until 81. But the two largest populations for gay men, statistically, per capita, were in San Francisco and Philadelphia. In San Francisco, a physician noticed in a large population of gay men that he was treating that they were developing a pneumonia from a fungus called pneumocystic pneumonia. Our immune systems clear that right away. So you have to be very ill or exposed extraordinarily large volumes of fungi. You just don't get that normally. And then he began to research it and then subsequently found that aspects of their immune system had collapsed and tied it to this virus that eventually was identified as the immune. He coined the term AIDS, acquired immune deficiency syndrome. 5 years earlier, we were seeing that. Philadelphia, I knew very friendly with a number of members of the gay male population. My ex, we had just started. We were just engaged, and we were living together. And maybe if you heard this, you're hearing it again. She said, "Why don't you met my downstairs neighbor John?" She goes, "He's gay." I said, "Okay." She goes, "I just want you to know I have to be his date for the office party, for the Christmas party, the awards dinner, the whole deal." Because there was talk about zero tolerance. It was horrible because people of alternative lifestyles, whatever anybody's individual opinion was, totally it's their business. And I said, and she asked me if I had any objection. Why would I? Because he needed to. Because if he had come out, it's so much different today than it was then. He would likely have lost his job. It's terrible. It's a great object lesson. People need to be tolerant of each other. Nevertheless, and he was a much better dancer than I was. She had a good time. Very true. Very true. So we were very, very friendly with all the folks in his orbit. And he would say, "Oh, did you meet?" Because I'm sitting there having lunch with a guy who could hardly, he was in pain every time he reached for something. He had AIDS. he wasn't going to survive. They would say, oh, he has it or he has it. And all they say was it. They knew there was something going around. I saw 2 cases of Kaposi sarcoma in a 6-month period. Most physicians don't see one in their careers. It's crazy. We were seeing it. We didn't know the correlation. Retrospectively, we learned about the correlation. The fact that there was this age was demonstrating itself was eminently clear to anybody who was part of that population. Fascinating. So I don't know what happened to him. We lost touch over the years because we moved out of the Philadelphia area. So it was a long, long time ago that happened. And so this is just a comment of this. We know the sexually transmitted, and this thing from infected moms. Understand that there are certain conditions. You're going to maternal child nursing, where you're in that area, they need to get evaluated. You don't generally want to use antivirals during pregnancy. For HIV, you do. You can with the right antiviral cocktail, you can significantly reduce the risk, very significantly statistically, to the unborn child. I can't tell you how important that is because it's a slam dunk that they're going to be HIV positive if you don't do that. I mean, you can reduce the percentage dramatically. And we knew this way back then, much less now. And so, these are, you can read through this as well as I can, all of these problems that are attendant with immunological dysfunctions that occur. Yeah, I don't think this is, even though the thymus gland shrinks, most of your T cells have developed a great deal. So I think they're just dysfunctional. This starts by the time you're age 17, you shrunk significantly. Your immune system isn't failing. And I think that's whoever wrote this PowerPoint didn't know what they were talking about. So the immune response itself, okay, yes, elderly people, higher risk of infection, I'll buy that. As you can see, the levels are they different? Yeah, particularly as you get older. Antibodies don't work as effectively. There's changes in the amount of immunoglobulins. Yes, and particularly as people get older, that's when a lot of times boosters are recommended. Understand, older people, like we're tired of getting stuck every 16 seconds. You say, they're going to tell you the same thing. I told you this before. When's your last tetanus shot? Just tell them 2 years ago. They won't bug you. Oh, did you have that pneumonia shot? Yeah, 2 years ago. We'll be fine. They don't want them. So all those things, we make more autoantibodies. Even though the peak years for it to onset, it doesn't preclude it happening later. My autoimmune flare was caused by immunotherapy that I was undergoing for the cancer that I had. So it's a little bit different in that regard. And I think that basically covers everything here. I did want to introduce respiratory in the time we have left. This concludes the material for the exam. The exam will be Blackboard based. I'm trying to find out, think about when it would not be maybe toward the latter part of next week that we can figure out what day I can open a window. Some of the other students were suggesting Thursdays were a good day because I know you have labs Tuesdays and Wednesdays. The only people who have lab and they're stuck with me typically for a micro on Thursday. And if I can antagonize them, I will. Just saying. I like that. You're all looking at me strangely. So think about that. We're on that. So this is now, if you go back and go up and look at Blackboard, if I still have it cooked up, and I do, you're going to see this on week 4. Okay. This is the start of the respiratory unit. With as much as we have to cover in the time we have left, I know you went over respiratory, but I mean, there's some things anatomically for you that I will have to emphasize: respiratory, digestive, urinary, and for male and female repro. So there's what to do in this last 4+ weeks that we have. So I may dictate some supplementary lectures and YouTube them and send them to you, depending on the amount of time we have left. That's kind of why I want to do that exam that way. But the final is going to be here on site. I think you have the final what day? The Wednesday. Yeah, the other guys, we have some room in the classroom. Some of the people from A, I'm gonna have to find because they're at the very last exam period. I think it would be cruel and unusual punishment to make all of them wait. There's something tempting about that. You don't think I take pleasure from seeing people suffer? I'm not like that. Students, yes. Oh, you know, joking. That was a feeble attempt at humor. Moving on. Did you learn about this? Conductive division. Okay. We divide respiratory anatomically and physiologically. My focus is physiologically, but anatomically is important. The single most common diagnosis that anybody has in their lifetime, doctors see, nurses see, URI, upper respiratory. What does it mean to be upper? Well, from this author, it's nose, throat, and larynx. I'm with you. If you look at the Marine textbook, the one I often flip-flop back from, they have nose and throat. Larynx is part of lower. Larynx, from all the textbooks I've used over 25 years of teaching this stuff, the larynx is like the dividing line. To me, if you get a cold and you end up with laryngitis, that's upper. If you start with, I can hardly talk, and the next thing you know, you have pneumonia and you can hardly breathe, that's lower. So to me, the larynx is a dividing area. I would never ask you, is laryngitis either upper or lower? That's the wrong kind of a question. I might ask you if it's a dividing line between upper and lower. That would be accurate. That's anatomical. This, and there's some anatomical things that are important. This is physiological. You have two divisions, the conductive and the respiratory exchange division. We define them anatomically, but they're not anatomical per se. Conductive division is all about moving the air down. So everything from your nose, your mouth, your throat, all those big bronchi and bronchioles, until they get to the point where those tiny tubes are microscopic and opening into what are called the alveoli. I'm sure we learned about that in lab. The alveoli are these sort of grape-like clusters of cells, and they're really just cells where the exchange takes place. So the conducting division is all about moving it to the area where they're very close to the cells. At that point in time, okay, it changes over. You're going to see anatomically something called respiratory bronchioles. And in that division, at that point, we don't have to move the air for the exchange of oxygen and carbon dioxide to take place. Simple diffusion takes over. It's almost like we're taking it all the way. The door is where it's going to take place. Conductive, by pressure change, it gets to the door, to your boom. And it's easy enough for one to go in the door and one to go outside. And really, that's some substance of what respiratory, easiest system to define. But in with the good air, out with the bad. AISS. Keep it simple, stupid. I love that. Look at the first sentence, first bullet. Specialized to bring oxygen in and expel carbon dioxide. What a country. I love that. And yeah, in the meantime, what does it do? Your nose and your throat. Nose hairs filter. They moisten it with mucus, saliva. And by the way, they take it from room temperature to body temperature because it's much easier for the exchange to occur without, thank you. The Almighty didn't like my last joke. If you get a chance, it's probably totally inappropriate with the humor they use in it, but watch History of the World Part 1 by Mel Brooks. 1980. He's like he's Moses. The Lord Jehovah has given me these 10 commandments. Kabalt. Sorry. Moving on. So aside from me being irreverent like that, so more in order to facilitate the exchange, you need the temperatures to be close. Okay, and the whole idea, the conducting system gets it into the lungs and to those air sacs, and the exchange takes place. Yeah, sounds are part of it. Yeah, smell, even augments taste. All of those types of things are part of it. pH, what happens? Your respiration is about involves that. When you're like last night, when you're exercising, when I was at the gym last night exercising, showing off that I went to the gym last night. When you were exercising, and you're when look as my heart rate starts to go up and I'm on the treadmill, what do you start doing? You breathe faster. Why? Because you're generating a greater amount of lactic acid, and the only way to compensate for that pH wise to continue the activity is to expel carbon dioxide and simultaneously bring in enough oxygen to recycle everything. So you're adjusting that pH, so you're blowing off the carbon dioxide. So in this unit, we're going to explore, and we also do the same thing a little bit in kidney, that carbonic acid buffer. Buffering is important. So this is one of the ways we do it is respiration. Other ways we do it is through our kidney as well. And so there's a lot of terms. When I think of respiration, there's two types. They call external and internal. To me, it's pulmonary, what's going on in your lungs. If you want to say ventilation, that's fine. And to me, cellular, not so much getting it there, but basically cellular to me is both how it gets to the cells and the exchange that occurs between the capillaries and the cells themselves. I mean, I think it's paralysis because every author has a different way of describing it. And these are fine too. And I wouldn't ask you specifically what they are without defining them very clearly for you. And again, here you can see nose, nasal cavity, sinuses, pharynx, which is throat, and they include the larynx. The other thing that you see in this, and I'll have to see what anatomy I include on the final exam and make sure I specify it for you. I mean, typically in lab, when I do the AP1 labs, or the AP2 lab rather, I mean, we go over all those different, you go over like cricoid cartilage and thyroid cartilage, tracheal rings, C-shape, open posteriorly. You did. Okay. What is this is an anatomical difference. Are these the same where they bifurcate? Is this like, no, why? Because the one over, it's got to get over the heart. This one kind of goes straight down, and this one has to make a sharp left to go over the darn heart's there. That's an anatomical basis for disease. Most pneumonia, which by gravity, particles getting into the lung, microscopic or otherwise, are right-sided. The other anatomical basis for disease, right here, that guy, that's pointing to the eustachian tube. So go to your ear anatomy. When a baby is born, okay, their eustachian tube between the middle ear and the throat is like this, almost horizontal. When the baby sleeps, anything that's draining is going to get drained back toward their eardrum. Hence, the large amount of middle ear infections. By roughly age 4 plus or minus, that as the baby elongates, that declines. And so the eustachian tube is now pointing more downward than horizontal, significantly so. So roughly by age 4, those stop because now when you're sleeping, it's like that. That's an anatomical basis of disease. Those are really important. I mean, I'm sure many of you had multiple ear infections. I'm sure some of you had tubes in your ears. My daughter had 2 sets of them. And then this cartilage in the middle where they split, it's got a fancy name. It's important. It's called the carina. Carina. I don't know where they named it. Very sensitive. So when particles do come down, that vigorously triggers your coughing reflex. We're going to go back and start with the lung on Friday. Thank you very much. And we're done.